Hi everyone, welcome back to Goggle Docs for our weekly video here on our YouTube channel. Just going to go around everyone to make sure you know who we all are. So I'm Amrit, we've got Kevin up in Scotland,
hello,
Amar, and we've got Patrick as well. So welcome back everyone. Anything that's come up in the last week, guys, that you think is quite topical that you want to discuss before we move on to the main segment of our video today?
Yeah, I mean, well, there's only one place really to start from the last week. I mean, I like these kind of new trials when they come out and all these kind of data. And part of the reason why I enjoy it with you three is that we really kind of talk about and around things about these kind of things. So the main thing that came across was really this colchicine data for COVID-19. The ColCORONA trial, and we did a little video on it earlier, just about the kind of the background and talk about it, based on really a press release. And what's happened next is kind of just expanded so much, and it's so fascinating. Really, and it's we've got a preprint out now, which kind of explores it in more detail. Of course, it's a preprint, so it's not peer reviewed. We're going to wait for that. But also we had a response from the authors as well, and yeah, it's taken a lot of kind of academics that really kind of
it sort of exploded on social media, didn't it, Amma? It was really fascinating. I mean, we were all very enthusiastic about it. And I said, well, we could chat about that again. I still think there's something there, but it's a great example of the press release not really matching what was in the meat of the study, wasn't it? And as you said, it exploded to such a degree that the authors felt they had to respond, didn't they, Patrick?
I think Patrick took offense to it.
Well, yeah, I mean, it's quite a long document explaining why they chose the 75 to stop the study at the 75% and why they changed the primary endpoint a little bit. It basically went on for such a length of time. I wonder, they just missed one little bit, which was my dog ate the paper. That's what I thought was missing. That's
Patrick, would it be helpful, John, just for our viewers' benefit, John, just highlight some of the facts that why it exploded on social media?
Well, why it exploded on social media? I think we had the press release. And then we had the preprint, which came out, and that's as Martin Landry, who's involved in one of the UK colchicine studies, said it was a travesty. So it was a travesty in terms of those two aspects. I mean, to me, it looked like they ended the study early, and there's a number of reasons they give. Although I was rather irritated that one of them was they wanted to announce it in January, which I think I understand it to some extent, but we want the right data at the right time, rather than maybe the right data but not quite polished. Anyway, so they did that, so they explained that, but so they stopped it early. They lost the power in the study. Their p-value went out the window. So instead of being a statistically significant event, it missed it. And then, but there was so they changed the primary endpoint from COVID positive based on both PCR and symptoms. It was only a small group based on symptoms, but they excluded those and just focused on the PCR positive. Now, it was something they said they were going to analyze, but not as the primary outcome, I don't think. Anyway, that was my view. So it was, but as you say, I mean, they wanted, when in their excuse, rather strong words, but anyway, in their reply to some of the challenges, and and this actually I think is a perfectly reasonable. Just because it didn't hit the p-value of 0.5 doesn't mean it's wrong. And certainly, the bulk of the evidence is still persuasive. I'd still take it. I suppose, going back to a comment I've said before, I'd still take it. But it's a shame that what was a really important study, and one of the excuses is they were running out of money. Important studies like this shouldn't do. If it was a Canadian study, I don't know but if this was in the UK, I'm sure it wouldn't have run out of money.
I think we have a an appropriate meme for you, Patrick, to kind of highlight it, and hopefully we'll show it right about now. But I think, you know, it holds true, isn't it? Kind of there's a lot of expectation, and the press releases are meant to do that, and then when you get down to the actual nitty-gritty, it's not as good looking as the first, you'd argue. But I think the frustration with it really is everyone had high hopes because of the, you know, culture scene, and everyone kind of wanted it to, you know, there was really, it had a good, you know, chance of being successful, and we wanted to be successful. And also, you know, we've highlighted the importance of robust studies, and kind of the pandemic will not change what we're doing in terms of science. And it's just kind of just a frustration with that, because it could have, you know, it doesn't clarify the issue as such, you know, even if we've got that. And, you know, the PCR positive was really, that's some good data from the PCR positive ones, but it still allows, you know, has a bit of, you know, question in our minds. It's not a definitive answer. We may have to wait till recovery kind of to get that with culture scene.
I'm still not over that meme, to be honest. I think that's a brilliant meme of press release, abstract, and results. And to be honest, I think we're all looking a little bit like the results after the last 1 year of lockdown and lack of exercise. But it's really interesting, isn't it? How, you know, there's the excitement around the press release. And as I mentioned during our last video, I'm not someone who follows a lot of the press releases in that much detail, but this is, you know, it's something that to me isn't normal. I don't know, is this something that happens that often, or is this really out of the ordinary here?
I mean, recently there's been a lot more of these kind of press releases because of the craving for information and knowledge, and some kind of hope in a way with everything going on. So everyone finds, you know, tries to get it. Even with these vaccine data as well, there's all these kind of announcements beforehand, which, you know, I think is useful, but equally, I mean, it's we all know. I mean, for us, because we know this, we know to look for the actual data and look to review it. But a lot of people will be drawn in straight away from that press release, and that can sometimes be a bit of a potential worry.
And part of that is also from a commercial point of view, of course, isn't it? This is potentially commercial sensitive information, the vaccine stuff. These can really drive share prices, can't it? So there's, of course, that element of the press release as well, which is why you know, a lot of these companies have to announce these top line results. But I've got to say, I'm with Patrick though as well, in terms of considering using colchicine. I don't think we should throw the baby out with the bathwater, though. I know Patrick seems to agree with me there, because as I said last time, ultimately the regimen they used in ColCORONA was something we're very familiar with in primary care. Certainly, no larger a dose, and actually shorter duration than we might consider for prophylaxis. So I still think it's something I might consider. Don't get me wrong, I want to see that published paper and you know, make my own sort of scientific judgment call. But I think this is something for my, you know, higher risk patients I'd definitely consider, particularly because we really have nothing else, do we, available in our armamentarium to try and reduce those complications.
And just coming back to Amar's point about the recovery study, I mean, it may be that they're too poorly to benefit from this sort of treatment. So it's, and then you're left with this, what do we, you know, what should we do? But which is a shame. It'd be interesting to see what the WHO think in terms of, will they incorporate that in their living guideline, which is, yeah, so let's see.
I think that was the beauty of this study, that it was essentially in patients in the community. So pre-hospitalization, patients that we see every day in primary care, and you know, obviously the majority of patients with COVID-19 infection are in the community. So it's a shame. Talking about optimism with COVID, vaccines. This week has been a big week actually for a couple of vaccines that have announced the results from their trials as well. Kevin, I know you were particularly focusing on that during the week.
Yeah. Well, partly driven by today as well. So I was doing a vaccination clinic with my colleagues in North Berwick today. So we were very chuffed with ourselves. We vaccinated 394 individuals, but a good proportion of the individuals were asking us about all these vaccines available now, because as you're all aware, we had two further announcements, didn't we? The J&J vaccine, one dose vaccine, so logistically very advantageous. And I think top line was 66% efficacy with the new variants as well. And then also the Novavax vaccine, 2 doses and an 89% So we have a portfolio now of four or five vaccinations, the Moderna one as well. So it's interesting time, and incredible what we've when I say we, the royal we, what science have achieved in less than a year, isn't it? So it's going to be interesting times ahead over the next 3-6 months, potentially very confusing times ahead. I'm worried there's going to be vaccine mixing and matching going on, which is clearly not what the trials did. So,
but Kevin, it's been an important week because, as you say, the Novavax is going to be mixed in Stockton-on-Tees. So it's the first time Stockton-on-Tees has been in the news since Harold Macmillan was MP, I think.
Very good.
Yeah.
There will be trials coming out about kind of mixing vaccines in the future as well. There are some trials going on, so that might be something in the down the line which might come out as well.
Yeah, and something I think therefore from the patient's perspective, I know from our local vaccine hub, often patients are asking about the different types of vaccines and actually asking for a particular vaccine over another one. And it's as you said, Kevin, if we have 4 or 5 there, it is going to potentially increase that confusion, not only amongst patients, but possibly amongst clinicians as well.
Overall, the pace of research, the evolution of research is amazing, isn't it? Vaccines, we're talking about cardiovascular, renal, metabolic medicine. There's going to be a lot for us to look forward to during 2021, isn't there?
Yeah, absolutely, Kevin. And that's actually the focus of the main part of our YouTube video today. And we're going to actually be having a preview of the year, so a preview of 2021. And as Kevin said, there's a lot to be looking forward to. So we're going to start our discussion on that. Something that we recorded just a few days ago, and we hope you enjoy it. Actually, one thing I did want to just mention before we get into that main part of our video today is that if you enjoy what you see, please do subscribe to our YouTube channel. And also, please do add some comments as well, what your thoughts are about what we discussed. Would you use colchicine in the community? Is that something that you think you'd do? But what about vaccines as well? The discussions that you're having with patients about the different types of vaccines and potentially the patients who are concerned about vaccines being rushed through as well. So we'd love to hear your comments. So please do post those, and we hope you enjoy the rest of today's video. It's great to be back here again with the gang for episode 2 of our podcast series. So as I mentioned, and as Kevin mentioned as well, a lot to look forward to, I think, in 2021. But things are very much remote and virtual at the moment, aren't they? Not only in clinical practice, but in terms of meetings as well. And so really, we've also got to be thinking about the Congress, the diabetes congresses over the next year as well, and how they're going to be delivered. Now, my understanding is that a lot of them are still going to remain virtual, and there is the hope that potentially towards the end of the year, they might be in person, face-to-face, or perhaps a hybrid model of virtual plus face-to-face representation. So guys, what are your thoughts about the year ahead with DUK, ADA, EASD, and IDF towards the end of the year?
Yeah,
gutted.
Yeah, I was about to say, I saw these plans. I think last year I remember thinking, you know what, fine, I can get through this year. I think next year we'll start to have more in-person congresses, but that's all been thrown out of the water, a window now. We've got Diabetes UK are doing their week or 2-week-long virtual sessions for their congress. We've got ADA who've also said that it's all going to be virtual now. And we have EASD, which I thought actually out of all of them, be the one most likely to be in person. They were one of the first to say, no, we're going virtual. And the only glimmer of potential hope for any interaction is at the very end of the year, which I think is sensible, is IDF. And yeah, I share your kind of disappointment, but equally it provides opportunities for all of us, as we said, to explore what we can do in a virtual format and to take it further, because last year it was all kind of last minute in a way for a lot of the congresses. this year now we can plan, you can build on what you've learned from last year and think of how best you can get that interaction, which is what we miss, and how we can use the virtual format to get that interaction and to deliver something slightly different, I guess, in terms of what the standard Congress might hold.
Yeah, I agree. I mean, it was disappointing where last year, of course, but this year too. But I mean, it wasn't all bad, wasn't it? The virtual platform for conferences. I mean, having all the presentations on demand was fantastic, wasn't it? Because that's where we all met, wasn't it? At various congresses originally around the world. Because you just can't get to all of the sessions you want to, can you? At things like ADA. So having those on demand, the entire program, I thought was really helpful from an education point of view and a self development point of view. But of course, as I'm sure we all agree, the one massive factor that was missing was that social interaction, the social networking at these congresses, because it's great, isn't it? A lot who you end up sitting next to randomly in the congresses, learning from people, the big exhibition halls. I mean, these are massive, these halls, people you bump into or people you speak to at the, so that is obviously all very sorely missed, isn't it?
Patrick, you're a veteran of these conventions and conferences. I mean, what are your thoughts? I mean, how have you found the last year actually?
I mean, very different. I mean, I think I would just echo everybody else. I miss that social interaction. You meet people. I mean, we've certainly, I met Amar for the first time in Chicago at a conference. So it is where you often network. You can come across some of the leading lights in just random ways by just meeting them in the pub or wherever. And it's a great place to meet, and also an opportunity. Let's face it, I've been very privileged to see lots of beautiful places around the world, but I'm not optimistic about even the back end of this year. I think this particular pandemic seems to go on and throw spanners after spanners into the works. So we'll see. But and I think organizing, it requires a lot. I think if you're going to be going away to some far-flung place, maybe not even so far-flung. I've been to UK, it might be Liverpool or Glasgow or London, but you still commit time away. Whereas now there's this temptation, particularly when it's at the weekend, that you somehow carry on your work and then squeeze in what can be 24 hours of learning back to back on a weekend, which is just too much. So I think one thing I have learned in this pandemic is we've got to pace ourselves. And I think, so certainly going forwards, I'm looking to pace myself a bit more. And I think mediums like this, I mean, the reason we got together, I think, to do this was because we were missing that interaction and wanted to, learn from each other and just bounce different ideas or how we see the data and how we perceive that's going to change practice. So hopefully we're going to share. So on a positive side, we're going to be sharing a lot of these moments and maybe doing a bit of predicting like we would do going to a Congress in the old-fashioned times.
Yeah, I think you're such a veteran, Patrick. I think you traveled to your first Congress by steamboat, didn't you?
Well, yeah, that was my second one. The first sailing ship.
You walked.
Sorry.
So we're talking about congresses, and obviously there's the networking and everything, but also there are these big groundbreaking kind of announcements, aren't there, and presentations of some of the big randomized controlled trials, and that's still going to happen. So we've still got there's the agenda for DUK and ADA seem to be kind of emerging now. We've got some idea of what's going to be presented there, and I think actually today's podcast is actually just going to focus on some of the things that we're going to look forward to that are going to come up in the next 6 to 12 months. And perhaps that's a segue into us starting to have a bit of a very top line sort of summary of some of the trials that we're expecting the results to be announced for. So why don't we get on to that? Kevin, do you want to kick off with anything that you're looking forward to?
Yeah, I suppose I know we talked about it quite a bit previously, but heart failure is very much on the agenda for 2021 as well. Whereas 2020, 2019 was the years of HFrEF, 2021, well, we're hoping anyway, is going to be the year for HFpEF, heart failure with preserved ejection fraction. Number of studies, isn't there, coming out, hopefully to finally give us a strong evidence-based therapeutic option for people living with HFpEF. Currently, it's just largely symptomatic treatment, isn't it, for those with HFpEF? I know over the last couple of months, in fact, just December, spironolactone has been given a nod by the FDA for HFpEF. But that was quite controversial because that was based on this top hat data, which has been debated. I mean, perhaps we can discuss that another day. And I think Entresto has had a slight nod as well from the FDA as well. Again, even though that Paragon trial didn't quite meet its endpoint. So we don't really have a strong evidence-based intervention. But we have now Emperor preserved, empagliflozin and HFpEF coming in March. We'll study completion in March. And then we have two dapagliflozin trials, DELIVER and preserved HF, looking again at outcomes in HFpEF, but also preserved in particular is looking at quality of life outcomes in HFpEF. So, very exciting. What's my gut feeling? I'll be interested to hear yours. Well, we've not really had any real positive results, as I've already mentioned. Is this another area where SGLT2s are going to light up? I hope so, because it's the one area, of heart failure management that even our cardiologists admit is very challenging in managing those with HFpEF. Because largely the HFpEF is driven by comorbidities, of course, isn't it? And in fact, we're all share a passion for diabetes. The heart failure you tend to get with the diabetes tends to be HFpEF as well, doesn't it? So really interesting. I mean, what are your thoughts, everyone? What do you think? Do you think SGLT2s will shine for HFpEF as they have for HFrEF?
I'll go. I don't mind going first. I'm anxious that I don't think they will. That's I may be wrong on this, and you'll come back and have a laugh at me. But I think they'll just miss. I think there'll be a hint, and we'll be like we've seen, as you've indicated, with other whether Entresto and spironolactone. But whether that's enough, I don't know. But I mean, there is, on the positive side, we have seen outcomes in patients with heart failure, which, as you say, on some of these cardiovascular outcome trials, and as you're quite right, Kevin, most of those in people living with diabetes are going to be HFpEF. So we've seen benefits, but I think it's such a heterogeneous group of conditions. I think to expect one simple molecule to work, I think is optimism.
A bit optimism. I mean, I should have said
positives. Go on.
No, I was just going to say we have had a little hint, haven't I? Remember, we had the sotagliflozin trials. So yeah, was that what you're going to say, Amma? Sorry to interrupt there, because that was more HFmrEF, ridiculous terminology, isn't it? Mid-range ejection fraction, but it did show, I think, Amma, did a slight hint of a benefit.
Yeah, and I'm a bit more optimistic, but a guarded optimism. So I'm going to say it's going to show some benefit, but in a subgroup population. So whether the overall trial will show benefit, I don't know. But I reckon, as we all know, there'll be sub-analyses or sub-analyses, but there'll be one group that you'll find that it'll have some good, I think they'll show some significant benefit. So, well, relatively significant.
It's going to be slicing and dicing to
be slicing and dicing. I think there will be some benefits somewhere seen in those trials. I reckon so, but I don't know if the overall trial will.
And guys, just to clarify, is this trial still looking at patients with and without type 2 diabetes? Are all of these trials kind of now looking at that kind of wider group?
I should have clarified that. Sorry. Yeah, Emperor preserved is both people living with and without type 2 diabetes. Yeah. So, and I said, I very much will. Emperor reduced. So Emperor preserved. We're talking about people living with and without diabetes.
Okay. So time will tell. Time will tell. We'll come back to this clip of video, I'm sure, and critique those predictions, I suppose. I mean, SGLT2 inhibitors obviously will remain, high on the agenda, no doubt, this year. Was there? I mean, Amar, I know you mentioned some interest in DARE-19 with dapagliflozin.
So, SGLT2s have colonized everywhere, haven't they? They're done with diabetes now, type 2 and type 1 now. They're looking into, we've done heart, we've done kidneys, and now we're looking at COVID-19 because that's the biggest news story out of 2019 or 2020. So, yeah, DARE-19 is an interesting, well, as it says, a daring trial. Sorry. It's looking at dapagliflozin in people with COVID-19 to see if it has any impact on reducing complications of COVID-19, on cardiovascular, renal, and complications. We know that people who are admitted with the coronavirus infection can have quite severe reactions, and have a large part of the reason why they get so unwell is the cardiovascular impact and the renal impact, and so a medication such as dapagliflozin, or an SGLT2 inhibitor, which has some benefit in those sides of things, as we've all talked about, is that their theory was that maybe giving dapagliflozin 10 milligrams might reduce the risks of these complications. And we saw, time to, reduction in hospitalization for heart failure, time to, these outcomes was only, weeks, wasn't it, in some of the trials. So potentially this early benefit may be transferred to COVID-19, which is interesting, isn't it? The worry is that obviously the risk of ketoacidosis is a massive risk, and everyone is really hesitant in that situation because COVID-19 can drive insulin resistance and raise ketones and hyperglycemia. But that's the major thing, and that's why it's quite daring, and of course the risks of everything else. But if they do show it by chance, or if they do show some kind of signal, I think this goes beyond COVID-19 actually, and I think this is where it's very clever, because if you show some benefit in COVID-19, or the situation with COVID-19 means that these trials are looked at with interest, say fine, let's see if this has benefit. In the future, you could say, well, in that case, what about in people who, in the future are acutely unwell with multi-organ dysfunction, or who are acutely unwell with any illness, sepsis? Potentially, would a medication like this have some benefit in reducing, ITU admissions or problems with the heart or the kidneys in that situation? And I think that's in the back of the mind, there's something like that, thinking if we can show the benefit maybe down the line, and I could be wrong with this, but that's my kind of looking ahead thinking. Don't know what your thoughts are.
Yeah, it was interesting because I suppose in primary care, I know in our locality, we were sending out clear messages to clinicians about, the potential risks in patients who are acutely unwell, during the pandemic, who are currently taking SGLT2 inhibitors. So as you say, as you mentioned, Amar, it kind of goes against that completely, and no doubt will cause even greater confusion, amongst clinicians if there are positive results there. So it'll be interesting to see what comes from that. What do you guys think?
You've heard me waxing lyrical about sick day guidance. That's going to throw a real spanner in the works for me, I tell you. And that's why I suppose sick day guidance isn't prescriptive, isn't it? It needs to be individualized. But you're right, if this comes up positive, it's going to add that extra layer of complexity, isn't it, to counseling patients. So, dear.
Yeah, but it's worth pointing out this is in hospitalized patients.
Yes,
so and with mild to moderate disease rather than severe disease. But it does. But it is daring of AstraZeneca to do it, as the name suggests. But the rationale's clearly there. These are, even when you're giving your sick day guidance or not rules as such, but we do know SGLT2 inhibitors consistently reduce acute kidney injury. So, and yet we're advising stopping people at risk of acute kidney injury. So it's fascinating, and of course, some of the harms we see in COVID-19 are heart failure and as well as acute kidney injury. So and we know these agents work in those outcomes. So Yeah, it'd be fascinating. But as you say, it's yeah, this is not for primary care though. For us, I think to initiate, I think it's the like of AMAR in secondary care when they can manage decay and detect it at a very early stage. I think for sure.
Well, that's it. Given the current state of hospital occupation, you know, it's a mild to moderate illness, it's not inconceivable we'll be seeing these individuals in primary care and managing them in primary care, with only the very sickest in the hospital. So, yeah, I'm just postulating what the future might hold for us all. You know, so yeah, absolutely, I completely agree with very much domain of secondary care just now, but you know, we have to be open to the fact that it may well enter our domain in primary care too in the future.
Yeah, I might say a prayer before before going down that route at the moment, anyway. But it'd be really interesting to see what comes of that.
A dare, and a prayer.
Yeah.
We'll find out in about a month or so. I think it's out. The primary completion is about January, so this year now.
This year now, yeah.
We should see it.
Imminent. So yeah, maybe we'll come back to that at some stage soon.
So do we want to have a quick guess on what that's going to be? Bearing in mind, I mean, I think the primary outcome was about hospitalization, wasn't it? I think reducing hospitalization, is that correct? Or
it's not. It's outcomes. Is all the kind of cardiovascular outcomes. So renal. They look at competency. Look at renal. Look at cardiovascular. Look at mortality. They'll look at and also kind of how they were progressing over the 30 days or so. They haven't stopped it yet. That's a good sign. I don't know. I honestly don't know. I think I like it because there is scientific basis to this, but I don't know. I'm not even enough to actually even hazard a guess.
In a similar vein, I didn't mention there's a number of acute heart failure and SGLT2 studies going on, isn't there, this year? I think, well, maybe this year, I don't know, help me out someone, or maybe next year. But that's the next big question now. We know it helps chronic heart failure. You know, do our hospital colleagues, Amar, would you consider starting it during an acute exacerbation or unstable heart failure?
It's interesting. I mean, I guess one reason is because of treatment inertia, maybe the benefit within a short period of time. But I mean, sometimes you'd argue, what's the urgency if you could do it done, you know, a week or two down the line? We did a kind of a look at our hospital data, looking at people admitted with heart failure, and I did some work looking at whether we would be able to start SGLT2 inhibitors, and this was before the license change as such to less than 30, but we looked at that, and I'm sorry, to 30, sorry, and we looked at that, and a large number of them were kind of, you know, certainly 70, 80 plus. Their renal function was on the lower side for initiation at that point. So I'm not sure. Potentially at discharge you could start it. I think there's a reasonable option there. I think there is a role for it, yes. But I would say, unless there's any urgency, I'd probably kind of maybe create a quick follow-up clinic or kind of a quick follow-up plan to start them on it, or a delayed initiation or something like that.
Okay, let's put our crystal ball to one side for the moment, I think, and shine some light maybe on the GLP1 class. I know, Patrick, you were looking at some trials that were coming up later on this year, which actually are going to be presented at ADA, I think.
Yeah, so I think ADA is going to be a big year. So these are the ones we're talking about now, really are high-dose semaglutide. So that is a GLP-1. And the new kid on the block, which potentially has, well, I think it's already showing evidence it's going to be the most effective in terms of glucose lowering and weight reduction of them all thus far, which isn't a GLP-1, it's a GLP-1. So it's a single molecule which affects both GLP-1 and GIP. And I have to remind myself what GIP is, because it's, well, a gut hormone, obviously, but it's glucose-dependent insulinotropic polypeptide, just for those. But yeah, so we've already got some headline data on both those. So with semaglutide, it's known as the STEP program, and this is using semaglutide in people living with obesity. Some of them also have a comorbidity of type 2 diabetes. And yeah, we've got the obviously we're going to get the nitty gritty and which you really need with this, because they always give you the good stuff in the announcement. Then you find out why everybody's stopping it early when the full data comes out. But we've been that's already, the press release has already been out there for Novo Nordisk. And the headline was about it was about 11 kilogram weight loss in that, so it's pretty impressive. You know, bear in mind and this was doses up to 2.4 milligrams. You know, just to remind you, some of the data, it was about 6 kilograms when we're using the 1 milligram dose, which is the current top licensed dose of injectable semaglutide Ozempic. So that's yeah, that'd be interesting to see. There's the full data, and then for me, as I say, for me, I'm really looking forward to this tirzepatide data. So we're just getting the phase 3 data coming through. That trial program is called Surpass. I don't know who comes up with all these names, but anyway, Surpass. And we were discussing actually before this, there's another one which is focused on people living with obesity, which is called Surmount. So the Surpass data that we've already got, the first one, Surpass 1, which has already come out. And again, we're very impressive. So this was just against placebo, but we're getting I think it was about a 11% weight reduction on that, and we're getting it was a reduction in HbA1c just in excess of 2%, so about 23 millimole reduction. So that's, I've not seen any glucose lowering agent doing that. It's again a once I think it's a once weekly injection and subcutaneous. There's a whole bunch of these Surpass studies coming out, and they'll be popping out. They're looking at clinical trials. We probably will see most, if not all of them, I suspect, by the ADA. It might be one or two which come on later on in the year. And you know, I love these cardiovascular outcome trials because they're so big and we get to really understand them. But that one is not going to come out for a few years yet. But and there's some quite bold studies. You know, they're up against gelaglutide in the cardiovascular outcome trial. You've got insulin degludec, insulin glargine, injectable semaglutide. So that, you know, we've got it's fascinating data and really quite bold studies.
You know what
Edge, I was going to say educate or give us a quick refresher if you can. Just tell me again how the GLP1 works again. Are they both essentially incretin hormones then? Yeah.
Correct. Yeah.
The GLP1 is, I know, but is the GIP is just has an incretin-like effect again? Yeah.
Yeah. No, I mean, so these are incretins. I mean, GLP1 tends to be more potent than GIP, but yeah, we've got these dual agonists now, and I think there's others which other companies are developing, but this is the one which is ready to go. And first time I came across this molecule was back in a Congress. It was in San Francisco, so 18 months ago, and it was so tirzepatide is something I think we're all going to be hearing about, but that's a Lilly molecule.
I remember Patrick going crazy over that. Yeah, but
I told you it's a winner back then.
You did. I tell you what I am looking forward to, though. I'm looking forward to Amrit's face once we get these trials, when we start commenting and putting things like, "Oh, it surpasses all expectations," or something really fun-based, and he's going to roll his eyes and look at us and then try to distance himself.
Do you know what I'm really interested in actually is what that device is going to be like. Because for me, that's actually generally for us as clinicians, that's one of the rate limiting steps, isn't it? With the GLP-1 class, the type of device, adverse events, tolerability. I'm looking forward to actually getting into some of the nitty gritty. Obviously, we want to see what the primary outcome is in the first place.
Well, it's Lilly. It's a Lilly product, so that's a good heritage with
my understanding it's going to be the same. My understanding it's going to be the same device. So yeah.
That's been something that has been very favorable, hasn't it, during the pandemic when doing remote initiations of GLP-1s. So yeah, okay, brilliant. And I think just to kind of close off, because we don't want to go into too much detail in terms of trials, we've got one more trial that we would kind of earmarked as something to look forward to. We've got the FIGARO trial, so Finerenone, the mineralocorticoid antagonist. That's the one. Got it out in the end. So looking at patients using this, patients with type 2 diabetes and diabetic kidney disease with albumin in the urine. And this is the cardiovascular outcomes that are being looked at, because we had the Fidelio trial late last year that was that came out, I think, in the New England Journal, that showed the results for the renal outcomes, which were favorable.
So yeah, we briefly talked, I think, didn't we, about Fidelio and Finerenone. So this is something that has yet to be licensed, actually. So it's not something that's being prescribed at all at the moment in the UK. But that's going to change again during 2021, and I think we're going to talk about license changes shortly, aren't we? But this is, as you said, the FIGARO trial, also in DKD, but it's a primary cardiovascular outcome trial with secondary endpoints. But interestingly, the mean eGFR in this study is above 60, high 60s actually, and around about half, or maybe just under half of the people recruited have evidence of microalbuminuria. So certainly a cohort that hasn't been looked at in great detail anyway in the past from the other renal studies we've discussed in our previous podcast. So going to be very interesting too. You know, Fidelio was positive, was very, very compelling, and as we said, it's probably going to confuse matters for us in primary care, isn't it? We're now starting to prescribe SGLT2s purely for the progression of renal disease. First new therapeutic option since ACE inhibitors and ARBs, sorry. And now we not just have SGLT2s, but this Finerenone as well. So interesting times ahead. So yeah, that's looking to complete later this year, FIGARO. So we'll have those results at some point, probably this half, hopefully this half of the year as well. So yeah, lots to talk about.
Brilliant. So you mentioned license changes, Kevin. Do we have anything that's imminent?
Imminent. Probably the dapagliflozin on the back of DAPA-CKD, which showed benefits in preventing the progression of CKD in people, again, with and without type 2 diabetes. So we'll probably have a dapagliflozin renal license. I don't know, what do you reckon, by middle of the year, probably April, May?
Before the middle of the year.
Yeah, before the middle of the year, for Q1 or Q2. So that, and then hot on the heels of that will be empagliflozin on the back of Emperor Reduce. So I know we were talking about Emperor Preserve, but empagliflozin will have its HFrEF license probably about the same time too, as well, actually. Perhaps a little bit earlier. So those are the immediate two that jump to mind, and the Finerenone I mentioned as well. I imagine will be licensed at some point this year.
And I'm interested in how they're implemented, because that's the point. They'll get licensed, but what for me would be actually how, once the license does change, how it's implemented into practice. And we see, same thing with the DAPA license and that changing. How is that implemented into practice? And with primary care, with secondary care, with cardiologists, with nephrologists, with diabetologists. How does that work? And the practical application of that will be really interesting, because
that's what you were saying about the GLP1s, Amrit. That's the nitty gritty we need to know in primary care, isn't it?
Yeah. Well, something that might help is an updated NICE guideline. The controversial topic that we really have to address, because we've been waiting a while, haven't we, Patrick?
Yeah, well, or will it? Because we're talking about complications here, and I suspect what the NICE guidance will focus on is glucose management. It might bring in some of these aspects, but I know NICE is specifically looking at the role of SGLT2 in chronic kidney disease. So that's a separate NICE guidance, which I think is about to get going. But obviously, everything's been a bit delayed with COVID. But I don't know. I mean, it's speculative, but I think, you're absolutely right. NICE is so important to us. So when it comes to how we implement this evidence into practice at scale, without postcode lottery, depending on who's reading the New England Journal each week. So it is important, but I've got a sneaky feeling it will be glucose-centric still, although maybe I'm wrong. You're shaking your head, Amrit. You're more confident than me.
I'm certainly not more confident than you, but I'm just hoping it's not so glucose-centric, because that start again, it gives a very conflicting message in terms of what we have as national guidelines and international guidelines.
I don't think they can be. I don't think they can. I don't think
I
they can
agree.
now. It's been forced in a way. Their hand's been forced in a way to include that, because all our societies are incorporating that, from the renal to the cardiology to our own, and also local levels at CCGLs. We're starting to change some of our local guidelines already to incorporate these things. So it'll have to be mentioned at some point. How much detail? Yes, that's the question.
You know what NICE should do, don't you? Leave it to sign.
Go on, Kevin. Go on. Tell us more.
No, on a more serious note, just on what NICE are doing, are we not due a TA on technology appraisal on dapagliflozin and heart failure? Or has that been
out? That's out already.
Is it out already? Sorry, I wasn't quite, because I in Scotland, of course, we tend not to follow NICE, so I'm not quite. So that's out already. And so what does that say then specifically?
Pretty much what we're
discussed. Okay, so
we're doing really, or we're suggesting, utilize it, and it just basically provides that validation to say, yep, you can. And it's about, and it's being used by the right people. So it's about, it just provides that backing, which is what we wanted.
I suppose one of the challenges is that clinical data is coming at us thick and fast, isn't it? And how NICE manages to incorporate that in their wider guidelines for type 2 diabetes management is going to be very tricky. So I don't know how. I suppose it comes down to the principles, moving away from that glucose-centric approach to give room to maneuver for the trial data that is very clearly focusing on complications of diabetes. But that's my hope.
Yeah, well, I suspect. I mean, I said that it would be glucocentric. I don't think it'll be completely like that. I think if you've got atherosclerotic disease, they will tell you to use certain agents. I think that will be there. But remember, they lock the evidence, at the beginning of this. So they do their own meta-analysis and cost-effective analysis as well. So all this, all the data we've had in the last year, when it comes to heart failure, when it comes to chronic kidney disease, I suspect that won't be captured in that guideline. I think there'll be separate guidelines for those. And NICE does this. It will say, refer you to this, that, and the other. We had a blood pressure update, and it referred, to a chronic kidney disease blood pressure target, for example.
Not really helpful, that though, is it, Patrick? I mean, it's really unhelpful when you're sat there with a patient, for example, or looking after you've seen a patient, and it's amazed to follow all these. I mean, it's all comprehensive stuff, I don't doubt, but we need some, 1 page or couple of page. But then I appreciate, as you said, this such a huge quantity of evidence. Now, I mean, what we need is one of these living documents, isn't it, that the ADA and other organizations have produced that are contemporaneously updated with the latest data, don't we?
I'm not sure about the renal side, but I think the cardiovascular side, there will be something there for sure. They can base it on the previous evidence we have. I'm interested to see what happens with GLP1s, given what we know about cardiovascular cost, benefits, where do you place them, and everything. So I think GLP1s will be interesting to see how NICE are going to sit with that. But we could talk forever on. We'd have a separate session on this, to be honest, couldn't we?
Yeah, that's a really important point, I feel, because that's a question that keeps on coming up time and time again, especially at the moment where you look at ADA EASD guidance versus NICE and the various kind of limitations or criteria that have been set by NICE. So
yeah, I'd love to see GLP-1 second line alongside all the orals, but it's not going to happen, is it? Oh, well, I suppose never say never.
We'll come back to it.
Never say never. All right, guys, I think perhaps time to wrap up. Any sort of burning things that you're looking forward to that we've not covered? Or do you think we've covered most things?
The only thing quickly, just in type 1 diabetes, obviously we're focusing a lot on type 2, but type 1 is a lot about closed loops and, closed loop algorithms. And in type 2, it's all about medications and these trials and things. In type 1 diabetes, it's all about technology. And there's a lot coming our way this year. And I think this is where technology will really, I think 2021 is where we'll get a lot more out of it. from Libra and the change Libra 2 to closed loops to these apps which also have these CE marks and CAM APS. So lots of things, and we can that's what's my add on to that.
And
so if I'm not
plenty to chat about this year, the four of us, aren't we? So we're looking forward to our regular discussions. So I hope
absolutely. Any closing comments? Should we all pick one thing that we're looking most forward to in the next 12 months? Patrick, do you want to go first?
Yeah, I was gonna mention just there's a nice update in terms of using high dose liraglutide, and I think this next year there's going to be a big focus on the management of obesity, as a fallout really from COVID. So I think there's going to be a big focus, and I'm optimistic about GLP-1. It all depends on the cost, but I am optimistic. These are fabulous agents, I think, for people living with type 2 diabetes and without type 2 diabetes. So I think greater access to those will be a great step forward.
Brilliant.
I'm on a slightly different note. I'm looking forward to hopefully getting together with you three as well, and actually in person at some point to actually discuss these things. I know soppy, I know, but that's probably what I am most looking forward to. Yeah, I mean, apart from that, would be the preserved trials that we talked about. I'm really interested in the HFpEF trials. I think that'll be something.
I think that's, I suppose I started with that, but the HFpEF literature, I think, is going to be very interesting today. And it's anybody's guess at the moment, as Patrick alluded to, how they're going to go. But it's something, I think, something we will be talking a lot about during 2021.
Yeah, I was going to say the same thing as you, that romantic notion of meeting up in person. But putting that to one side, I think, the GLP-1 progress over the next 12 months will be interesting. I mean, from a local perspective, we are involved with a low-calorie diet pilot scheme, the NHS England program. So that's been running since late last year. So I'm quite interested to see how that kind of translates from trial into practice. So again, thinking about remission, but also weight loss as well.
On that note, I should say I think I mentioned maybe last time, I've got 2 patients recruited into Direct, and they've just had their closeout visit. So Direct is closed out now. So I don't believe we're going to get interim data. We've had the 2-year data published, but I believe we're not going to see interim data. We're just going to see the final data presented. When, I don't know, but definitely very much to look forward to that, because NHS Scotland have promised that if the 5-year results are indeed positive, that I will be able to prescribe a low-calorie diet on a GP10. So the big bold promise there. Hopefully they'll follow through with that if indeed we have positive results from Direct. Yeah.
Brilliant. Well, we'll wait to find out about that. Fingers crossed. Well, I suppose that wraps it up for us on today's podcast. It's been great to obviously join you guys again, and I think this is the time where we have to plug our various things. So first of all, if you're watching this on YouTube, please do subscribe to our channel. That would be great. And then obviously we've got our Twitter and social media presence. And this is the part where I hand over to the experts. And so let's go to Patrick first. Your Twitter handle, please.
Okay, so my Twitter handle is Dr. Patrick Holmes. That's it. Holmes, just in case people don't spell my surname, which lots of people don't. Anyway, there you go.
Mine's at Amarput, AMARPUT.
And mine's at Dr. Kevin Fernando, DrKevinFernando. Also on LinkedIn as well.
And mine's at Dr_Amrit Lambert. But I have 0 presence on Twitter at the moment. But if anything happens, these 3 guys will let me know for sure by WhatsApp. So it's a bit of an indirect kind of thing going on there. But great. Thanks for joining us. And we hope to see you all soon. Take care, everyone.
Bye-bye.
Bye-bye.
Bye.